My name is Dr. Michael Petroziello. I'm one of the interventional radiologists here at Roswell Park. As an interventional radiologist, we're really a subset of radiologists that perform minimally invasive procedures under imaging guidance, and basically to treat and diagnose a variety of diseases throughout the body. So that means less risk, less pain, less recovery for patients, and get them out of the hospital sooner. The variety of procedures that we do can range anything from venous access, meaning getting access to your bloodstream to deliver treatments, to biopsies to diagnose diseases, things like embolization and ablation, which specifically target the tumor, and then also delivering treatments specifically to organs such as the liver, kidney, and lung. So ablation is an alternative to surgery. So if a patient can get to surgery, that is our goal. However, only 10 to 20% of our patients can achieve surgical resection. And ablation is used when we're dealing with a small number of tumors in the liver. We usually say 3 or less. And that would be the ideal patient, either if it's primary or metastatic. So ablation is really an umbrella term we use, meaning that we use imaging guidance to direct a needle into the tumor within the liver. And from that needle, we direct an energy to kill the tumor. And the energy can be a variety of things. We talk about thermal ablation, which means that we can apply heat or cold through the needle to either burn or freeze the tumor, or we can apply electrical energy through the needle to disrupt the electrical gradient of the tumor and kill it that way. Ablation can be repeated. There's no set limit on the number of ablations that you can do, depending on the location and number of lesions, however. Embolization is a technique where we're essentially directing a small catheter into the blood vessels which are supplying the tumor. And with embolization, we're doing 2 things. We're cutting off the blood supply to the tumor, and we're also using that opportunity to directly inject a substance into the tumor to get it to shrink and die. And that substance can vary. It can be chemotherapy, what we call chemoembolization, or it can be radiation therapy, which we call radioembolization therapy. So the key with embolization is how we deliver the treatment. And both with chemoembolization and radioembolization, they are attached to small beads that we inject through the end of the catheter. And with radiation in particular, these beads are quite small. And we watch under imaging guidance as we inject the radiation particles, and they preferentially get taken up by the tumor, and over the course of time, that radiation works to get the tumor to shrink. We can use these therapies to supplement the chemotherapy, or also give the patient a chemotherapy break or holiday to reduce the side effects of the chemotherapy as well. The techniques of what we call interventional oncology, ablation and embolization, are not found at all hospitals. There is a lot of nuance to the procedure. It's important to come to a center that specializes in these procedures and has a lot of experience in it.